Good morning, everyone. I'm so sorry that I can't be there in person, but fortunately through the wonders of technology, I'm able to participate from afar. So this morning, I want to talk about concussion management and the differences between children and adults. I do have some disclosures. So I am a member of the Board of Directors of the Canadian Academy of Sport and Exercise Medicine. And as a member, my travel expenses are covered by CASM, although I do not have any financial support specifically for this presentation. I'm also, I'm just at the 6th International Consensus Conference on Concussion in Sport, and as an expert panelist, my travel expenses are also covered for that. So through this talk, I'm hoping that participants will be able to recognize the differences between children and adults when it comes to concussion presentation and management, as well as being able to apply the management principles of concussion to different age groups, and be able to advise patients with concussion appropriately in terms of return to activities. Over the last 2 decades, there has been an explosion of research in the concussion field. Most of this research has been focused on adults, but there has been a gradual realization that children are different, particularly in how they present with concussion and how they recover from concussion. So there has been a trend recently that there is an increasing focus on adolescents in the research. But unfortunately, there's still little research in the younger age groups between 5 and 12. After the 5th Consensus Conference on Concussion in Sport, there's a systematic review published looking specifically at the differences between children and adults in concussion management. And that paper identified 8 areas of difference between the two groups, including the signs and symptoms of concussion depending on age, the differences in duration of recovery, the importance of return to school in the younger age group, and differences in terms of return to sport. Today, I would like to talk about differences in terms of the incidence and mechanism of injury of concussion in children, as well as the differences in child development and susceptibility to concussion, and how they present differently in terms of their signs and symptoms. Also want to review how the assessment of concussion differs between adults and younger children, and then look at management priorities in different age groups, and specifically looking at persistent symptoms. The majority of concussions actually occur in pediatric patients, so 2/3 of all concussions occur in children and adolescents, with a peak in the 10 to 14 year age group. The mechanism of injury is also different between adults and children. So at the extremes of the age spectrum, so the very, very young and the very, very old, falls are by far the most common reason for a concussion injury. In adolescence, however, sports and recreational activities are by far the most common reason for a concussion. And again, that peak is seen in the 10 to 14 year age group. There's evidence that children are more susceptible to the effects of concussion and take longer to recover. So adults typically recover within 2 weeks, whereas children can take 4 weeks or longer. And there's evidence that children have more significant neurocognitive deficits resulting from concussion. So there have been a number of studies looking at memory dysfunction following concussion, and what it's found that high school students have more memory deficits than college-age students. And there's emerging evidence that that may be true for the younger age groups as well. Part of the reason for that is that children are developing throughout childhood and adolescence in a number of domains, including physically, cognitively, socially, and emotionally. There's a study by McCrory that showed that there is rapid cognitive development up to the ages of 15 to 18, with the highest degree of development in the 9 to 15 year age group. This cognitive development can actually mask injury-related cognitive impairment, so it can be more difficult to assess cognitive deficits following concussion in growing children and can be more difficult to quantify. The signs and symptoms of concussion have been generally categorized into different categories, including somatic symptoms such as headache, blurred vision, feeling nausea, cognitive symptoms including difficulty remembering, difficulty concentrating, and mental fogginess, sleep issues including more sleep than usual or not being able to sleep as well as they typically do, and fatigue would fall into that category as well. And then there can be a lot of emotional symptoms, so irritability, sadness, anxiety, and concern about missing school and work. In adults, by and large, they're able to identify and verbalize their symptoms. However, in younger children, they may not recognize the signs and symptoms of concussion, and they may not be able to verbalize them to the same extent as adults. So symptoms can be missed. And often children present with more behavioral concerns, such as being more clingy, more irritable. They may be crying more often. They may complain of tummy pain rather than headache or nausea. So the particular symptoms may be different in this age group. In terms of assessment, there have been a number of tools that have been developed to help with the assessment of patients with concussion. The SCAT-5 tool was created for patients 13 years and older and is designed for patients who are able to fully verbalize how they're feeling and what their symptoms are, and has a cognitive screen that is more appropriate to older children and adults. It was noted, though, that younger children, less than 12, weren't able to do some of the cognitive tests that were on the SCAT-5. And so a child SCAT form was created that has a different symptom report as well as a simpler cognitive assessment form for younger children. In particular, both of these tools are available online for free if you want to download them. And in particular, for the child SCAT, there's actually two symptom reports. One for the child, which has more child-friendly language. So rather than nausea, it says, "I feel sick to my stomach." And rather than fatigue, saying, "I get tired easily." So it's more understandable for children. And there's also a parent report to augment the child report to get a more fulsome idea of how the child has been affected and is behaving post-concussion. In terms of management strategy, the general ideas are the same across all age groups, but they're applied a little bit differently depending on the age. So the initial management recommendation is a period of rest for 24 to 72 hours to allow symptoms to decrease and to prevent recurrent injury during that highly symptomatic period. Following that initial period of rest, recommendations include a gradual increase in daily activities, including school, work, and physical activity. And there have been stepwise protocols that have been developed to help guide these areas. I'll go into more depth about all of these areas. So the idea for rest is that when you have a brain injury, if you continue to do cognitive activities or physical activities which make the brain work, that can increase symptoms and particularly increase the number and severity of symptoms and potentially prolong recovery. So rest is thought to help prevent prolonged recovery. And as long as activity is maintained below a subthreshold activity level, so as long as activity doesn't exacerbate symptoms, you can be a little bit active after that initial period of rest, but you want to make sure that you don't increase your activity to exacerbate symptoms. A particular concern for students with concussion is return to school. And in the literature, there's evidence that depending on the study, anywhere from 10 to 75% of students have difficulty with that transition back to school. So some patients are able to get back to school with no problems. They don't need any modifications, and they're able to get right back into it. But there is that subset of students who may take more time and may need more help in that progression. So a stepwise protocol has been developed to help guide the return to school. So after that initial period of rest, students can start to increase their daily activities as long as it does not exacerbate symptoms, so staying below that subthreshold level. As symptoms improve and they're able to do a bit more, they can start doing some school activities at home. So reading, watching TV, doing some computer work. And as long as those activities do not exacerbate their symptoms, they can continue to increase those. And if they're able to do at least 30 minutes of cognitive activity at home without exacerbating symptoms, then they can start looking at going back to school on a part-time basis. As they return to school and their symptoms improve, as long as their symptoms are not exacerbated by being at school, then they can increase by going back to full-time attendance. That process of return to school for a lot of students needs what we call academic accommodations. So these are modifications to their environment, the curriculum, or testing strategies that help them get back to school without exacerbating their symptoms. In terms of school absence, it's important that this period be minimized. Typically, it's about 2 to 4 days, but you won't want to keep students out for more than 7 days because you start to see detrimental effects from that, including social isolation, withdrawal. Mental health issues can increase because it's important for students to have their peer group interactions and to normalize their schedule to help minimize over-medicalization of their symptoms. So it's important that children are returned as quickly as possible without exacerbating symptoms. And it's important to recognize that you don't have to be totally symptom-free to go back to the classroom. The idea is that you want to go back in a way that is safe and that is not exacerbating symptoms, but you're still able to be there for to participate in some way. So academic accommodations can help with that process. There are a whole number of accommodations that you can institute, and these are typically symptom specific. So for instance, if children are experiencing light or noise sensitivity, they can wear sunglasses in the classroom or sit away from windows. They can use earbuds or headphones in the classroom and avoid noisy areas in the classroom and have a quiet area for them to go if they need to take a break. Or if students have a lot of anxiety, providing reassurance and support from the teachers that they will be provided with accommodations and reducing workload can help a lot with anxiety levels for students who are worried about missing school. A return to work strategy, which is similar to the return to school strategy, has been developed and is available on the Parachute Canada website. Again, this is a stepwise increase in the amount of activity that patients are participating in, with the idea that they are keeping at that subthreshold level, so not doing anything that exacerbates symptoms. So after an initial period of both physical and cognitive rest, they can start doing some light physical and cognitive activity at home. As long as that does not exacerbate symptoms, they can start doing more work-specific activities in preparation for returning to work. And again, as symptoms improve and their activities are not exacerbating their symptoms, they can return to work on a reduced working schedule with accommodations as needed. So similar to school accommodations, being able to take frequent breaks, having an area where they can go that's quiet, and altered tasks as needed. As they improve, they can go back to regular working hours with accommodations as needed, and then finally a full return to work as tolerated. One of the most controversial areas in management of concussion is return to sport. And the reason for that is because this is the highest risk of re-injury, and particularly in younger patients. Going back to play while still symptomatic carries a risk of catastrophic brain injury if they were to be hurt again. And we obviously want to avoid any exacerbation or worsening of symptoms and recurrent injury. So the strategy for return to sport, again, is a stepwise increase in activity. It's important that this return is medically supervised to make sure that patients are not proceeding through this too quickly and exacerbating symptoms, and to ensure that patients are given the appropriate advice for each step. So again, after that initial period of rest, patients can start some symptom-limited activity as long as it doesn't exacerbate their concussion symptoms. They can move on to light aerobic exercise, and that can include walking, biking, swimming, yoga, anything that's non-contact and non-impact, and as long as it does not exacerbate their symptoms. As long as symptoms continue to improve and symptoms are not exacerbated by activity, they can move on to sport-specific exercise. So for running sports like basketball and soccer, that would include running, so 20 to 30 minutes at a moderate intensity. For hockey or figure skating, that includes skating, so again 20 to 30 minutes of moderate activity. If they're okay at that level with no exacerbation of symptoms, the consideration is to move on to training. I specifically ensure that patients are symptom-free before they go on to practice situations and gameplay. And as long as they're able to continue with non-contact activities without exacerbation of symptoms, at that point, they can be medically cleared to go on to contact and gameplay. Again, at each step, making sure that symptoms do not recur or are exacerbated by the activity. The important thing with the stepwise increase in sport is that each step should be a minimum of 24 hours, but each step can be variable in terms of how long a patient is in that step. So for patients who are still symptomatic, they should be remaining in the first 1 to 3 steps. And as I said, they should be symptom-free before they move on to practice and gameplay. Some general principles to keep in mind with return to sport. Because of the risk of re-injury and worsening of symptoms and prolongation of recovery, if you go back too soon, as soon as a patient is suspected to have a concussion, they should be pulled from sport that day and not allowed to go back to sport that day. Even if symptoms resolve fairly quickly, they should not go back to play that day. And they should not go back to contact or gameplay until all symptoms have completely resolved and they've been medically cleared to go back. The other caveat is, particularly with students, they should be fully back to school, keeping up with all the academic demands, and be totally symptom-free with that before they return to gameplay. With children and adolescents, the return to sport should be more cautious and take a little bit more time than with adults, just to make sure that they are completely symptom-free before they get back into a situation where they could be re-injured. Other management items to keep in mind with concussion patients include sleep hygiene. So sleep is very important for recovery from injury, and for children and adolescents it's actually very important for their normal growth and development. And we know that sleep can be affected by concussion, so it's important that sleep is optimized to improve recovery. Taking frequent rest breaks can help with recovery so that the brain is not overexerted. And pacing yourself through the day to help manage fatigue is important for recovery as well. Specific symptoms may need further management. So for instance, headaches may require medications and more attention to sleep and rest if headaches are not being controlled. It's important for patients to maintain their social networks and interactions because support is important for the recovery process. For older patients, avoiding alcohol, drugs, and driving are very important because reaction time can be slowed because of the effects of concussion, and the addition of alcohol or drugs may further impact reaction time. And for driving, because reaction times are slower, there's an increased risk for the patient and for others because of that. It's also very important that concussion patients have regular medical follow-up so that symptoms and recovery can be monitored. And if there are problems with recovery, that these can be identified early and interventions can be instituted at a timely fashion to help improve the recovery process and avoid prolonged symptoms. So there are a number of active treatments that can help patients with concussion. Massage therapy can help with neck pain and neck muscle tension. Physiotherapy and chiropractic treatments can be very helpful for patients with headaches, neck pain, balance problems, vision problems. Patients with visual deficits, and particularly if they have persistent headaches, blurred vision, difficulty focusing and concentrating, they may benefit from visual therapy. And for patients whose emotional symptoms or mental health is worsened by the concussion, they may require medications or psychotherapy to help manage those symptoms. As I mentioned, recovery for adults is typically within 2 weeks, and for children it's about 4 weeks. But depending on which study you look at, up to 50% of patients may actually have persistent symptoms lasting beyond weeks and months. And there are many reasons for that. One reason is that the diagnosis of concussion may have been missed or delayed. So the patient may not have sought medical help at the time of the injury, and they don't go until several weeks or months later when the symptoms are persisting. The concussion may not have been recognized at the time of the injury, either by the patient or medical staff, and so the diagnosis may not have been made. For some patients, they may not have medical follow-up, so they are not having the monitoring of symptoms and recovery that is ideal, and they may not be getting interventions in a timely fashion to help with the recovery. For some patients, they may not comply with treatment recommendations, and they may be active in cognitive and physical activities, and that may exacerbate symptoms and potentially prolong recovery. And then the other possibility is that there is another diagnosis to explain their symptoms. So there's a large overlap with symptoms of concussion with other entities. So concussion symptoms are not specific to concussion. Neck injuries present with a lot of the same symptoms, and mental health issues can have a lot of similar issues, as well as chronic headaches. So there's a lot of other diagnoses that may present with similar symptoms. There have been a number of predictors of persistent symptoms that have been identified, including historical factors such as history of migraine in either the patient or the family, prior history of mental health issues in either the patient or the family, and prior history of concussions. Intrinsic factors include female gender in younger patients, particularly adolescents, higher symptom loads and higher symptom severity at time of assessment. Particularly symptoms of headache and dizziness have been associated with a more prolonged recovery. And there's evidence that patients who continue to play on the day of injury are at an increased risk of prolonged recovery. So one study showed that they're almost 9 times more likely to have prolonged symptoms beyond 21 days. So managing persistent symptoms can be quite challenging, and it often it requires going back to confirm the diagnosis. And that may involve investigations such as CT, MRI, neuropsychological testing, reviewing patients' activity levels to see if they're doing too much or too little. That may be hampering their recovery. They may require medications to help manage symptoms like headache or mental health issues. And at this point, you may need to refer to specialties to help with specific symptoms, so neurology, neuropsychology, psychiatry or psychology, or if you're not comfortable managing concussions, sending them to a sport medicine or other concussion expert to help with management. Multidisciplinary clinics can be very helpful in this setting because they have multiple health professions in one center that can help maximize treatment for patients with prolonged symptoms. There have been many guidelines that have been developed for both pediatric and adult age groups. The Canadian Pediatric Society guidelines are now out of date, but the American Academy of Pediatric recommendations have been updated in the last 4 years or so. The Ontario Neurotrauma Foundation has a pediatric concussion guideline on their website, which is a live document and is regularly updated. Adult guidelines include the Consensus Statement on Concussion in Sport. The last one was published in 2017. This is largely adult focused, but they do have child-specific recommendations. The Ontario Neurotrauma Foundation also has adult-specific guidelines. And then there's a Canadian guideline on concussion in sport available on the Parachute Canada website. And as I mentioned, so take-home points are management for concussion initially is rest for a few days, followed by gradual increase in daily activities, including sport, work, and sport. And active treatments can be very helpful for patients in terms of managing symptoms. And keeping in mind that depending on the age group of your patient, these recommendations may need to be modified and tailored to your age group. So as I mentioned, I'm currently at the 6th International Consensus Conference on Concussion in Sport. And the guidelines will be updated in spring of 2023, so keep an eye out for those. Thank you so much, and again, I wish I could be there in person. I hope you enjoy the rest of the conference.